there it is. Thank you very much. So a bit of background information about my research is that Mid-North Coast Cancer Institute operates as a paperless system, including e-prescribing operating on the Mosaic database. The electronic booking system has pre-allocated times for chemotherapy treatment protocols, resulting in a very structured system. However, the previous oncology outpatient treatment nurse allocation system was ad hoc, chaotic at times, and did not fit with the structure of the booking system, and it resulted in an uneven work distribution amongst the nursing staff. In conjunction with that, in 2017, in January, we commenced the first year new graduate rotations, first year graduate nurses rotating every 6 months, alongside with second year graduates that are rotating on a yearly basis. So, and the challenge faced with that is we only have a part-time clinical nurse educator to support both those new graduates during their placement. On average, the Mid-North Coast Cancer Institute at Coffs Harbour treats about 30 patients a day, whilst also training and supporting the 2 new graduate nursing staff and managing more complex and extended length of treatments that actually resulted in staff having to work back overtime and extending the treatment times in order to get the treatments completed efficiently and safely. This ultimately resulted by June 2017 an increase in sick leave in nursing staff and also staff burnout. Bless you. So the aim of the research was to, what we actually did is a core group of senior nurses and the nurse unit manager got together and met initially to find out to address the issues of the increased patient acuity and the current nursing skill mix that we actually had within the treatment room. The core group, we discussed the idea of maybe looking at a new allocation system that may actually work for us, and that came along with the introduction of the a new procedure that came out along with that we worked with. We collaborated with the treatment room, and it's key to when we started looking at this new allocation system is it was working for the nurses in the treatment room, so it was key that we identified with the nurses to actually talk to them to actually find out what they thought might actually improve our allocation system, and that was really key and important. And also to discuss how we were going to ensure that we supported our new graduates, which actually represent 30% of our nursing staff in the treatment room. So the aim of the system was to improve the work environment, to reduce the sick leave, and ultimately to improve patient safety as well whilst in the treatment room. So the methods of the research. So the allocation model included one team leader, which was usually a senior nurse, supernumerary, didn't take a patient load. We had 2 new graduates and 4 other senior experienced nurses working in the treatment room administering the chemotherapy. Mid-North Coast Cancer Institute, Coffs Harbour, is funded for 11 chairs. So we booked to 11 chairs, and we have 2 side rooms for other procedures if we need them or to keep people isolated. The system actually involved having the team leader smooth the schedule for the day, so the bookings are pre-scheduled in, and they actually look at the bookings for the day to spread it out and to smooth it out and allocate a nursing staff to 2 chairs. So what actually happens is the team leader will allocate one nurse to 2 chairs depending on the skill mix, and obviously a new graduate that's only in their first year is going to be very different to a 8th year RN working in the oncology treatment room that's very experienced with complex treatments. So we needed to make sure that we're allocating appropriately for the nursing staff. We also looked at the extended length of time that the nursing staff were actually having to stay back, and we looked at changing our staggered nursing start times so that the start times, we had one shift at 7:30 to 4, one shift 8 till 4:30, 2 shifts 8:30 till 5, one shift 9 till 5:30, and 2 shifts 10 till 6:30. So we extended our operating times up until 6:30 to ensure that we actually could fit in the treatments. Now the key thing is that one staff member was allocated to 2 chairs adjacent to each other. We've got quite a big room, probably about the size of this room, and what was previously happening before is that we'd have one nurse looking after a patient right at the back of the room and then also over here and another person would be working. So it was created a very chaotic traffic within the treatment room system. So allocating one nurse to 2 chairs adjacent to each other, they knew that their patients were only coming into those 2 chairs throughout the day, and they'd actually decrease the excessive traffic in the treatment room as well. The start of the day, what we actually do is we, as I said, the team leader the day before allocates all of the treatment schedules, and a list is printed out for the nursing staff the day before. So when the nursing staff comes on in that morning, they have their list of 6 patients that they're going to be treating for the day, and they can pre-plan their day. They can look at the patient's information, look at their patient's history, and actually go through it. And this was really imperative with the new graduates. When they come on, there's a lot to take on, there's a lot to process, and new systems where, as we said, we're fully electronic and e-prescribing, so it was a lot for them to take on. So to be able to plan their day was actually, they actually found that quite useful. And also the nursing staff in the treatment room actually book the next patient's chemotherapy bookings. So they're all responsible for doing that, and that put a bit of ownership back onto the nursing staff to ensure that they actually are not double booking into the chairs. So they're actually, it put a bit of responsibility back on the nursing staff to ensure that we're actually booking our patients in appropriately. We also introduced a fast track chair, which is basically for things that are fast procedures. So very quick in and out, subcut injections, intramuscular injections, port flushes, PICC dressings, things like that that are fairly quick and simple. And we can book up to 10, 11 patients in the chair, the fast track chair. So it's very quick procedures. We actually identified that this was a good area for the new graduates to start on when they first came to our treatment room within the first week or 2 of their first placement, because it was more familiar treatments. They would get used to the process of working in oncology outpatient setting, doing the assessments, using the electronic systems, but also just feeling a part of the team and doing familiar treatments. That usually, depending on the nursing staff, would stay there for 1 or 2 weeks, and then they'd transition out into the other chairs and actually start to do cannulations and infusions. So it was a little bit more support and allowed the clinical nurse educator to work with them as well a little bit better. The other thing we introduced is a morning team meeting huddle, and that was this imperative because it actually helped to introduce with communication and discussing with a multidisciplinary team. So each morning we come on first thing, and we have the doctors, we have nurses, allied health, and actually have a discussion and future planning about the day ahead. We talk about potential issues that have occurred the day prior, or any potential issues, hypersensitivity, drugs that patients may experience that we need to be heightened aware, because we are about 7 to 10 minutes walk away from the main hospital, and that's how long it takes one of our JMOs to come down if they're not in the department. So it's imperative that we let them know at this time we may need you down here for this. We also talk about just the general operations, if anyone's got meetings and so forth, so we can plan the day and to make sure that their patient load is covered whilst they're at a meeting and things like that. So, and that huddle only takes about 5 minutes, and it's put together the day before by the team leader. The results of the research was quite good. Basically, one of the key things with this is that there was a key leader that was involved in putting this together, and we met when we initially first started this new allocation system. We met on a monthly basis to collaborate back with the nursing staff to make sure if they had any further inputs, adjustments and so forth, and adjusted it as we went. So we did actually, it's key to have a leader to help drive this and make any modifications, because there was some modifications we made along the way to fine tune it. Some of the implications that we encountered along the way. In oncology outpatient setting, challenging the traditional nursing ethos of getting the work done before lunch. We just want to get in there, get in the morning, 8 o'clock, get it all done before lunchtime so we can write all our notes in the afternoon. And trying to change that and really make sure that, embed that we're doing contemporaneous notes and actually spreading out the treatment throughout the day so that we are actually safe as well and getting our breaks. Resistance to change. Sometimes change can be quite daunting, and when there's something new that has been implemented, it was quite scary, particularly in nursing, making some changes. But one of the things that we said to the nursing staff is that we will trial it for a period of time of 3 months, and if it doesn't work, we can go back to the new system, and they found that quite useful. The extended hours till 6:30, and the medical support, we ensured that the medical support also was around or available for us with the extended time. The outcomes, there's been quite some good positive outcomes. We've had an increase in weekly occasion of services without any additional resources, just by structuring the allocation system. It wasn't our initial plan, but it was one of those things that happened as we reviewed. We've had a 55% reduction in time in lieu since implementing this new allocation system since August last year until January 2018. Improved risk management with a multidisciplinary team being involved. Staff actually reporting that they're less fatigued because they're not running backwards and forwards all over the treatment room. It's more specific targeted treatment where they're treating the patients. They're aware of their workload, and it matches the nursing skills to the required treatments. And so far the staff have reported that the staff have been surveyed, and the feedback from the staff have been quite positive, and they actually like the new system and think it's been quite supportive of it. And also patients have been surveyed as well, and the feedback from the patients is that they've actually found that the treatment room is a lot calmer and less chaotic, which is positive. And we've recently rolled this new allocation system out to the Port Macquarie Mid-North Coast Cancer Institute, and that's been well received and very positive as well. So, and I'm currently rolling out into our radiotherapy department. So it's got potential to be adapted and modified depending on your team. Thank you.
Thanks, Belinda. That's a really powerful presentation. I congratulate you on your change management skills. Yeah, there must have been significant challenges there. Does anyone have any questions for Belinda? I think it's really fascinating. This afternoon we've seen lots of different types of tools to improve safety and quality in cancer care, from high-level frameworks which apply, broadly, to things like Belinda's, which have really very maybe a narrower scope but highly effective at the local level. And it's a good reminder that we can all get involved in the development of tools to improve safety and quality for our patients, no matter where we are in the system. I don't have any specific questions. There's one down at the front. Yeah.
What helps, say you concluded saying that it can be...
Just
sorry.
start again, sorry, yeah, thanks.
Belinda, you concluded by saying that this method that you're using can be applied to other waiting areas and treatment departments. What makes your methodology so flexible that you can do that? How did you build that into your methodology?
I think with our current booking system, it allows that. So I've actually modified our booking system and put start and stop times so that we can actually really structure it accordingly. We don't actually, we block out chairs so that if a nurse starts at 10 a.m, that chair is not open till 10 a.m. So you can really structure it, and it's got the capacity to structure it, where before it was just open and people could book in at 8 o'clock. You could have 6 patients booked in at 8 o'clock with 2 nurses on. It just was never going to work. So just looking at really blocking out and using the system to its full capability. So I think that's what we've done, and it's just looking a little bit differently and how to approach it. Thank you.
Thanks, Belinda.